Well, good morning. As Kim said, there are a couple of reasons why this topic is important for you. First of all, it's relevant in the care of our patients. If you are taking the certifying examination, it is a hurdle. You must pass the ECG part in order to pass the board examination. And for recertifiers, electrocardiography is incorporated into a variety of case presentations and testing material there. So it's very important, I think. Over the next few days, there will be 7 components to the ECG review. First of all, this morning I'm going to begin with a few comments about how test questions are selected, the format typically used for the board examination and the principles of grading, and some hints about taking the test. And then we're going to talk about a brief review of ECG patterns that are associated with chamber enlargement and hypertrophy, focusing on right ventricular hypertrophy since you see LVH all the time. Then intraventricular conduction abnormalities, AV dissociation and heart block, and selected aspects of myocardial ischemia or infarction, including patterns that can simulate or that can mask infarction. And then we'll talk about drug effects, electrolytes, and STT wave abnormalities, and some miscellaneous patterns and cardiac arrhythmia. The board exam simulation is similar in format to the examination administered by the board. That is to say, it has about 37 tracings and a 2-hour time limit. The board examination, of course, is computer-based, and a tutorial for that is at their website, and obviously one would want to be very familiar with the use of electronic calipers and with their tutorial before taking the test if you are a certifier. Saturday, there will be an optional component where we'll just look at a variety of other electrocardiograms. So over the course of the review, the simulation, and the Saturday session, I will present to you about 145 electrocardiograms. They cover essentially all of the material that the board has indicated is testable from their standpoint, and I say that based on the board answer sheet that they provide to you. All the electrocardiograms I'm going to show you today are in your book. All of them are standard electrocardiographic diagnoses that any clinical cardiologist should be able to recognize. So I'm not going to show you a double junctional tachycardia with retrograde and antegrade AV block at different cycle lengths. We're going to talk about fundamental things that you all see every day or every week and should and are able to identify. So first of all, for the certifiers, a couple comments about the ECG test. The first point to make is that the ABIM is not, it is not their intent to trick you. It's made up of people like you and me. The board are practicing and academic cardiologists who sit around a table and go through the electrocardiograms. Every electrocardiogram on the test has to be acceptable to everyone on the panel or it's thrown out. It has to be demonstrate a good testable point, not too many other things thrown in that will make it difficult to interpret and introduce anomalies, and it has to be one that can be graded. The questions are also analyzed both pre and post-test, and even after the test, they're tested to see if they discriminate between those individuals who have done well generally and those who have not. So it really is an intent to be fair. My advice is to read the tracings as you would in the heart station. Just look at the electrocardiogram and then interpret it. Secondly, analyze all the material provided. Even though there is no intent to trick anyone, you do want to look at the header, look at the age, look at the entire tracing. Don't just look at the most dramatic finding on the electrocardiogram. You should, of course, excuse me, familiarize yourself with the answer sheet, including all 94 potential answers provided by the board. And as I indicated to you, I'm going to show you electrocardiograms of each of those. Excuse me, I'm sorry. But now we get to the tough part. For the certifiers, there is a challenge, and that is the ABIM answer sheet. When you look at the answer sheet, several things will stand out to you. First thing is that there are a number of things that are not on there that you use on a regular basis. There is no RV infarction. There is no ST segment elevation MI. There is no AV nodal reentry on this answer sheet. And the reason for that is that the board has used this answer sheet and this examination for a long time. And they track questions, they track content areas. They know that at certain times congenital patterns are not recognized as well, or maybe it's supraventricular arrhythmias, and so they track this over time. And because of that, they've kept this answer sheet the way it is. It is a challenging answer sheet. So as I say, what I would do is read it as you would at the heart station, then try to reconcile your answers with the options that you have on the answer sheet. The scoring, each question typically will have about 10 points, and various components of the answer based on the importance to the tracing will be allotted those points. There will be some answers for which you'll get no credit either way. You won't add or won't take away, just because it's not relevant to the main testing point. There are some answers that if you put, you will lose all 10 points because it would be detrimental to patient care or potentially dangerous or contradictory. You can't, for example, put both Mobitz 1 and Mobitz 2 heart block as an answer for a tracing. So you should just try to reconcile it with how you would read it in the heart station. For some of them, a clinical diagnosis will be evident, but you should only select those findings that are definite and that you consider important, and that's a quote from the board instructions. In your material, I've also given you the sample question that the board provides, the electrocardiogram, and how they have scored it. So let's move on then. Let's talk about some electrocardiograms, and let's begin with straightforward LVH, left ventricular hypertrophy. You see every day and know readily how to identify, characterized by increased voltage, and the diagnosis strengthened by the presence of secondary STT wave changes, often the left axis and or left atrial abnormality, and intrinsicoid deflection prolongation, classic left ventricular hypertrophy. You know the characteristic STT changes. There are downsloping ST and asymmetric T wave inversion. Here there is some left atrial abnormality. The axis is normal, straightforward LVH. A little bit of right precordial ST elevation because of the deep S wave is part and parcel of LVH. And the T wave is discordant to the R wave. So if I were taking the test, I would put answers number 40 LVH, number 67 STT wave changes secondary to LVH, left atrial abnormality, and sinus rhythm. There are a number of algorithms for detecting or scoring left ventricular hypertrophy. I've listed two or three of the more common, based on the voltage, in some cases based on points, and adding in these other factors such as the left axis, the intrinsicoid deflection, STT change. I can tell you on the board examination what you would be held to. It would be one that is pretty clear-cut LVH. It's not going to be one that barely makes it by one set of criteria and not by another, and you have to resolve that. That's not going to be a testable point in my estimation. So you will be asked to recognize LVH that is pretty clearly present. Each of these has its own limitations. First of all, you should know that most of these were derived from middle-aged patients. They are not very reliable, not reliable at all for children and young adults. Most of them did not involve large numbers of women in determining the normals, the Cornell being an exception. And they obviously don't take into account habitus, which can affect things as well. So there certainly are limitations. That said, the electrocardiogram, some of these patterns can be highly specific in the appropriate populations. For me, the most common and ones I used are the Sokolow and Lyon voltage, but greatly strengthened by the presence of the STT wave change. And importantly, remember the limb lead LVH, R wave and AVL of greater than 10 or 11 millimeters. Now, we said left atrial abnormality is commonly present in LVH and strengthens the diagnosis. Prominent notching of the P wave, especially in lead 2, with a P wave duration of 120 milliseconds and a leftward shift of the P wave axis. And then in V1, there's increased duration and depth of the terminal negative portion of the P wave, at least 1 millimeter for 40 milliseconds. Remember, you know well, the left and right atria are sequentially activated, so unlike the ventricles, it's pretty easy to distinguish right and left atrial abnormality or enlargement, and even biatrial, because we have the right atrial first and then the left atrial. Right atrial, just to mention it while we're talking about this, peaked P wave in the inferior leads generally greater than 2.5 millimeters, rightward shift of the P wave, and an increased area under the initial positive portion of the P wave in V1, again, about 1 millimeter for at least 40 to 60 milliseconds. And the axis is just provided in there for your reference. Here's another pattern of left ventricular hypertrophy in a patient with chronic aortic regurgitation. This is a pattern we used to call a diastolic or volume overload pattern. That term is not in vogue anymore electrocardiographically, but you should recognize that this is an accepted pattern for a certain kind of LVH, characterized by the prominent voltage, but often these deep, narrow septal Q waves and upright T waves, in contrast to the classic STT wave inversion of concentric left ventricular hypertrophy. So this is a chronic aortic regurgitation. And on the answer sheet, I would put number 40 LVH and number 9 sinus bradycardia. Here's another example of LVH, but a peculiar kind. And again, look at the entire question, a 29-year-old patient with syncope. You're struck by the fact that there is increased voltage here, but look at the size and depth of these Q waves, and they're pretty broadly present all over in a 29-year-old who passed out. And so the diagnosis here is hypertrophic cardiomyopathy. And on the answer sheet, I would put LVH, and this is one I would put the clinical entity of left ventricular hypertrophy, of hypertrophic cardiomyopathy, again, taking into account the header and the pattern. Here is a patient with apical hypertrophic cardiomyopathy, characterized, as you know, by this pretty prominent and symmetric T wave inversion in the mid or lateral precordial leads in a 44-year-old patient, also with very prominent voltage. All right, so let's move from LVH to RVH. There are several patterns of right ventricular hypertrophy. There's not just a single pattern. Here is a classic pattern of concentric right ventricular hypertrophy. And you'll notice that there is a prominent R wave in V1 with an R equal or greater than 5 millimeters. There's a right axis deviation of the limb leads. There is a right atrial abnormality. Notice the initial positive over 1 millimeter, over 40 milliseconds. And so right ventricular hypertrophy, not only are there several patterns, but RVH is diagnosed by the environment in which it sits. So none of these are diagnostic by themselves. An R in V1 can be a normal variant. Right axis can occur in young, healthy adults. All of these taken alone can be different things. It's putting them together that makes this pretty classic concentric right ventricular hypertrophy. So for the test, the answers I would put are number 41 RVH, number 38 right axis, number 5 right atrial abnormality, and number 7 sinus rhythm. Here are some of those commonly used criteria for RVH. I've already said the R over S ratio in V1, or an R wave greater than 5 millimeters. Some use 7 millimeters. A QR in V1 can be indicative of RVH. Right axis deviation we've already talked about. The right atrial abnormality, or P pulmonale. I will show you in a moment an S1 Q3 T3 pattern and an S1 S2 S3 pattern, also reflections of the rightward axis in this setting. But let's look at the differential diagnosis for right axis deviation. Obviously RVH, that's what we're talking about. But you can also have right axis deviation because of a lateral myocardial infarction, because you've lost the left ventricular forces from the MI. A little later, I'll show you a left posterior hemiblock, which can also produce right axis deviation. It can occur with chronic obstructive pulmonary disease, even in the absence of RVH. And finally, it can occur as a finding in a normal young adult. I'll show you one of those as well. The differential diagnosis for a prominent V1 R wave or an RS ratio, there are several things that can cause that as well. Again, RVH. But ventricular pre-excitation, WPW, is another cause. Posterior myocardial infarction is a cause. Hypertrophic cardiomyopathy, I already showed you one of those. And if it's a QR, it could be an incomplete right bundle with a septal MI. Or finally, an R wave prominent in V1 can be a normal variant. Here's an example of a right axis, but the right axis is due to the fact that there's been an extensive anterolateral myocardial infarction. So on the board exam, I would put number 52 anterolateral MI, 29 first-degree AV blocks, 7 sinus rhythm, and 38 right axis. Here's an S1, S2, S3 pattern. Typically, S2 is greater than S3 in amplitude with RVH. The reflection again of the right axis. You can see the right atrial abnormality again. Prominent R wave in V1 greater than 5 millimeter and R greater than S. And persistent S wave across the precordium. And this is another example of right ventricular hypertrophy. So number 41 RVH, number 38 right axis, number 5 right atrial abnormality, and number 10 sinus tachycardia. Now, chronic pulmonary disease, as I mentioned, can affect the electrocardiogram because it can cause RVH, but can also affect it because of positional changes. The lower diaphragm, the vertical heart, changes in volume of the chest, and this can result in a poor precordial R wave progression, and it characteristically results in a QRS and lead 1 that is often low in amplitude with a P wave that is near isoelectric. We don't see a lot of these tracings anymore, happily, because smoking not as prominent as it was a generation ago. But these used to be fairly common electrocardiograms. Here's an example of one. This is a classic chronic pulmonary disease pattern. First of all, you see there's this low voltage, and look how low it is in V1. You can hardly see the P wave. Look at lead 2, 3 in AVF, and compare the area under the P wave to the area under the QRS. There's more voltage in the P wave than there is in the ventricle. So this is striking right atrial abnormality in this case. It's got this lead 1 sign, poor R wave progression. This is a chronic pulmonary disease. So number 5, right atrial abnormality, number 36, low voltage, number 10, sinus tachycardia, and number 81, a chronic lung disease pattern. So acute pulmonary embolism is another pattern that can affect the electrocardiogram in a manner that simulates RVH and right-sided changes. One pattern that can occur is an S1Q3 T3 pattern. I'll show you that in a moment. You often will have a rightward shift of the QRS axis, and there may be incomplete or complete right bundle branch block, and right precordial lead T wave inversion can occur. The electrocardiogram is a poor indicator in terms of sensitivity for pulmonary embolus, and there are a number of patterns, and so it's not often very helpful. When it's classic, it can be very helpful, but when it's classic, it's usually in the setting of a pretty substantial pulmonary embolus and hemodynamic changes that have occurred. Other findings that can accompany it are a shift of the precordial transition zone to the left, and importantly, ST segment deviation in the right precordial leads in V1 and V2. It can either be ST depression or ST elevation. Right atrial abnormality and sinus tachycardia is present, or there may be atrial arrhythmias, and we always are suspicious of PE in a patient who presents with new onset of atrial flutter. So here's an example of acute pulmonary embolus. The top tracing is the index tracing. The bottom tracing is the control taken 8 days prior to the event. And you can see there is a incomplete right bundle branch block with ST elevation actually in the right precordial leads here. There is a shift in the axis now, so there is an S wave, partly due to the incomplete right bundle, but there now is this Q wave inferiorly as well, and the T waves are inverted, so this is an S1, Q3, T3 pattern. So you can see we're simulating an inferior ischemic event and an anterior ST elevation MI, although this would be an unusual distribution, wouldn't it, for that. But in this appropriate setting, these are findings of pulmonary embolus when compared here. S1, Q3, T3, sinus tachycardia, new transient right bundle, and ST segment deviation in V1 and V2. So I would put in this examination, if this were on the test, 43 right bundle, number 10 sinus tachycardia, number 65 STT of injury, and number 82 acute pulmonary embolus, again with the appropriate header. Here is another example of right-sided finding, and the finding is incomplete right bundle branch block, RS, R prime. Interesting, it's not just that, is it? It's an RS, R prime, S prime. And that pattern can raise a little suspicion in our mind sometimes, and that suspicion can be an atrial septal defect. And in a patient with a heart murmur and paroxysmal atrial fibrillation, that supports the idea that it could be as well. And that's in fact what this is an ostium secundum ASD in an adult. The axis is a little bit rightward. In children, of course, it is classically a right axis with an incomplete right bundle. In adults, when you get in the 40s, a number of other changes take place, and the axis may be just slightly rightward or may even be normal. Now, certainly don't want to mislead anyone. In the heart station, you would read this as just an incomplete right bundle branch block, and these are a dime a dozen. They don't all have ASDs. So, but in the appropriate setting, it can be a reflection of that, and sometimes that RS, R prime, S prime can be indicative of an ASD. Remember, when it comes to atrial septal defects, the ostium primums have a left axis in contrast to the normal or right axis. The secundums have the rightward or normal axis in adults, and when you have a sinus venosus ASD, a low atrial rhythm is commonly present. The incomplete right bundle branch block is not fully understood. The classic teaching used to be that it represented a peculiar kind of hypertrophy of the right ventricular outflow tract because of the right to left shunt, or left to right shunt, and supraventricularis, the crista supraventricularis would hypertrophy, and that would give you that late activation because that area is activated late. But we also know that about 20% of these ASDs have a full-blown right bundle branch block as well. So whether this is just really a reflection of the conduction disease, the hemodynamic effects, or that peculiar hypertrophy is not clear. I mentioned earlier that the right and left atria, because they are sequentially depolarized, can be identified separately, and so it is possible in some cases to identify biatrial enlargement. And here is one. First of all, you see there is RVH, QR, but the R is greater, well, certainly greater than 5 millimeters. There's a right axis. So this is RVH. And by the way, when you have this kind of RVH with a QR, that often is indicative of quite elevated right-sided pressures, in some cases even approaching systemic levels. So this would be substantial RVH. But you'll notice the initial portion here, you can see the right atrial abnormality, and there is initial as well in the inferior leads, and then this big terminal portion as well. So this would be a biatrial abnormality. So 41 RVH, number 5 right atrial abnormality, number 6 left atrial abnormality, 38 a right axis, and you could also put STT changes secondary to RVH, but in this case, once you've made this diagnosis of RVH, I would give you full credit for that alone. All right, let's move then into conduction disturbances. And this just lists the ones, right and left bundle and the fascicular blocks. nonspecific intraventricular conduction delay. And then after we say a few words about these, we want to talk about functional aberrancy, the two important mechanisms, both acceleration dependent and the Ashman phenomena. And then finally, we want to talk about ventricular pre-excitation. So this is just a poor cartoon to demonstrate the sequence of activation of the ventricle. Remember, the very first thing that happens when the ventricle is depolarized is that the septum is depolarized left to right. So that means the net vector is going this way. So that gives us in 1 and L and V6 a little Q wave. And it gives us a little R wave over in V1. And then the mass of the left and right ventricle are depolarized, and this overwhelms the right ventricular side, and so we have the R wave and the S wave. Remember, when a vector comes toward an electrode, it's positive. When it goes away from the electrode, it's negative. And then the final thing, the depolarization goes up around the base in the back, which may or may not be reflected on the electrocardiogram. I show this for two reasons. First of all, you will see how it explains one of the findings of left bundle branch block, and it also helps to explain why left bundle branch block masks Q waves. So here's a classic left bundle branch block. First of all, let me point out that this right precordial ST elevation, again, is part and parcel of the left bundle branch block. Doesn't mean anything else but that. But you'll notice in lead 1, there is no Q wave. In lead V6, there is no Q wave because the septum is not being depolarized that way. So this would just be left bundle branch block and sinus bradycardia. Here is an example of a left bundle branch block obscuring Q wave infarction. Here's a patient. On the top is a control tracing, and you can see a inferior Q wave infarction. Patient then a day later or so, maybe the same day, developed a left bundle branch block and a nasty left bundle branch block at that. And you can notice that the Q wave is gone. You now have an R wave here, and it has been masked. And because that septum has not been depolarized left to right, the cavity is such, and the depolarization occurs diffusely, that you do not see the infarction Q wave. So a left bundle branch block can both sort of mimic infarction because of the ST elevation, right precordial ST elevation that occurs, and it can mask it by limiting Q waves. So we generally say in electrocardiography that when it comes to myocardial infarction, the left bundle branch block precludes you from saying anything definitive, and you have to rely on means other than the electrocardiogram. That's not absolutely true, right? You know that. It's generally true. There are a few patterns that can still be very suspicious for myocardial infarction, even in the setting of left bundle branch block. Let's look at a couple of them. Here's one, and you can see that this patient has not only a left bundle, but has a current of injury in the inferior leads. So you cannot see anything about the precordial leads here because that's part and parcel of the left bundle. But in the leads that have a prominent R wave, there should not be ST elevation. In fact, the characteristic finding is depression, right? So if you superimpose a current of injury in that setting, you can recognize it. So this would be an acute current of injury in a patient with left bundle branch block. And for the test takers, it would be 47, 65 STT injury, and number 9 sinus bradycardia. Now, some have proposed that the magnitude of the ST elevation in the right precordial leads can lead you to be suspicious as well that there's a superimposed current of injury. Some have said greater than 5 millimeters, maybe greater than 7 millimeters. I can tell you from personal experience, though, that is a not very reliable guide and has sort of fallen out of favor. You can be suspicious when there is marked ST elevation with the left bundle in the precordial leads, but I don't think you can be very definitive in most cases. But here's an example where I think you could be a little bit more, because not only do you have striking precordial elevation with the left bundle, but look at the pattern of it with this upward concaving wave going into the STT. And this would be very suspicious of a superimposed current of injury, particularly when you compare it to the left bundle control tracing shown below. Primary T-wave changes mean that if you have T-waves that are discordant from what you would expect with the conduction abnormality, you know we expect this to be upright, you know we expect to have inverted T-waves and ST segment changes in one and in the lateral leads. Here you could make an argument these are perhaps primary, but this kind of primary change that occurs in 1L and V6 is not very discriminating in terms of telling a coronary versus a non-coronary cause for the left bundle branch block. But what is much more important is if you see primary changes occurring in the precordium. The left bundle branch block, the characteristic thing is to see ST elevation and an upright T. If you see ST depression or flat and inverted T wave, that means something else has affected the electrocardiogram besides just the left bundle branch block. And so this would be primary T-wave abnormality, and this kind is very important to recognize. Particularly ST depression, which I'm not showing you, I've just shown you sort of a flat ST with an inverted or biphasic T-wave. So this one I would say left bundle branch block and ischemia number 64 and sinus bradycardia. Left anterior fascicular block, abnormal left axis, 45 to 90, negative 45 to 90 degrees. Often, and characteristically, in fact, a small Q wave in one in ABL. And the QRS should be normal in duration or only mildly prolonged along with it. The posterior fascicular block is a little more complex. There's a right axis of the QRS, often quite tall R waves with Q waves in the inferior leads. And the QRS duration is only mildly prolonged from the fascicular block, but almost all of the posterior fascicular blocks I have occur also in the setting of right bundle branch block, which I'll show you in a moment. And then you have to exclude an alternative cause of the right axis because there are other patterns that can simulate a posterior fascicular block. First of all, let me show you just a standard left anterior fascicular block, the axis to the left, small Q wave in AVL. You'll notice here there is poor R wave progression. That can be part and parcel of the left anterior fascicular block as well. And sometimes putting the electrode 1 interspace down will allow those R waves to be more evident. Here is the posterior fascicular block. Shown on the top is a control tracing. You'll notice this is not a horribly contemporaneous tracing because we don't see a lot of these anymore. In the pre-interventional and lytic days with acute ischemic events, these were occasionally present. They're much less common acutely now, it seems to me. So at any rate, you can see there are some changes here anteriorly in this patient having acute coronary syndrome of some sort. But shown below a day later is the development now of a striking right axis, tall R wave inferiorly with these Q waves in the setting as well of a right bundle branch block. This is a posterior fascicular block. You would have to have this control tracing because there are some congenital lesions with RVH that could look pretty similar to this. So you'd have to be cautious about that. But in this setting, for sure, this is a posterior fascicular block with a right bundle. Obviously an ominous finding because it means you only have one fascicle remaining of the conduction. So right bundle branch block and left posterior fascicular block and sinus rhythm. Okay, this slide shows a couple kinds of aberrancy, important to recognize. On the top strip, you'll see sinus rhythm. This is a lead V1, sinus rhythm going along. And then you see a couple intermediate patterns and then a full-blown right bundle branch block pattern. And this is gradually accelerating. And so this is acceleration-dependent right bundle branch block. The refractory period is not normal. And as the rate speeds up, it does not fully recover. And you get a various degree of aberrancy until it becomes fully aberrant. This is acceleration-dependent right bundle branch block. There is a much less common deceleration bundle branch block, which I would not predict would be part of a standard board examination, so I'm not going to show you an example of it. The second one shows a rate-dependent conduction defect, and this is the first really important thing I'm going to tell you this morning. And that is, whenever you have an irregularity on the electrocardiogram, the first thing you do is look for the P waves and look to see if there's a P wave hidden somewhere that could be causing what appears to be a ventricular beat. And this one's pretty evident because you can see you have two leads here, simultaneous leads. You can see that just at the end of the T wave, there is a P wave. It has distorted the T wave, and this is an APC, not a PVC, and it's aberrant because it's occurred early. And here it is a left bundle branch block pattern. So this is a rate-dependent left bundle, just as this was an acceleration or rate-dependent right bundle up here. But this is an APC with aberrancy, not a PVC. And if you were to have measured the P waves, you would have seen that that's exactly what it was, because this came early and interrupted the cycle. So that's one important kind of aberrancy, and that is functional or rate-related. Shown below is a different kind of aberrancy. And this patient actually has a lot of irregularity from the sinus and APCs, but this is most classically seen in patients with atrial fibrillation. You'll notice that you have a sequence here where you have a relatively long R to R compared to these, followed by a relatively short R to R, and then it conducts with a right bundle branch block pattern. That's called the Ashman phenomena, and this is one that you cannot figure out. You just have to know this. The beauty of electrocardiography is it usually is deductive, but this one you got to just know. And what you have to know is the AV node recovery time is dependent on the preceding R to R cycle. So if there's a relatively long cycle here, it will take the bundles a relatively long time to recover from this beat. So if the next beat occurs early, before it has had a chance to totally recover, you can have the aberrancy with the right bundle branch block. The refractory period of the right bundle is normally slightly longer than the left bundle, and therefore Ashman is most commonly right bundle in appearance. Now you'll notice it's not a striking prolongation here. And you may say, well, gee, this one is prolonged even longer. Why didn't this one? Because it's not just the amount of prolongation, it's the amount of prolongation and the amount of shortening of the next beat. It's the combination of the long and the short that gives rise to the aberrancy. And it's not just rate related, because there are other times when you can go just as fast and conduct normally. So it's not like this rate related here, where as soon as you get to the rate, no matter how you got there, it's going to be aberrant. Here, if it's not preceded by a long short, it will not be aberrant. And that aberrancy can be perpetuated for a beat or two by concealed conduction, which we'll not go into this morning, but just recognize that Ashman phenomena can be perpetuated for a few beats as well. So those are the two important kinds of aberrancy to recognize: acceleration or deceleration dependent functional aberrancy, and Ashman phenomena. So the top one I would, on the test, read as aberrancy and right bundle branch block, sinus rhythm, sinus bradycardia, and B, APC, aberrancy, left bundle, and sinus rhythm. Okay, so that was point number one. Always look in the preceding T wave if you have an irregularity, and even if it starts a run of tachycardia. Here's point number two: the difference between AV dissociation and heart block. They're not synonymous. AV dissociation merely describes the relationship of the atria and the ventricles. It's like saying you have a headache. Might be a brain tumor, maybe anxiety. It just describes the sensation. AV dissociation just describes the relationship. One cause of AV dissociation is heart block, but it's not the only cause. cause. So let's look here. In this patient, we see a regular rhythm occurring very regularly, and we see P waves, but we see P waves marching through independent of that regular rhythm. So this rhythm then is what? It's an accelerated junctional rhythm. And this rhythm is what? It's a sinus rhythm. But they are totally independent. So there is AV dissociation here. None of those P waves capture. Is there any heart block? No, there's no heart block here. We didn't see any P wave that should have conducted that didn't. This one was getting ready to conduct for all we know, and it was interfered with by that simultaneous depolarization of the junctional focus. So interference can give rise to AV dissociation, even in the absence of any block at all. So this one would be number 22, junctional tachycardia, number 10, sinus tachycardia, and number 35, AV dissociation. Junctional tachycardias, by the way, are characterized by their regularity. And what you would do if you were in the heart station, you would take your calipers and march this through and be sure that you didn't see a beat that occurred early, a ventricular beat. Because if you did, that would mean that you did have capture, and that, in fact, there was not total AV dissociation. All right, heart block. We don't need to dwell on this. You know it well. Just a couple of terms and a couple of points. Remember, with Winkie-Bach, one of the characteristics is that there is a progressive shortening of the RR interval until the P wave is non-conductive. That's important not for AV nodal Winkie-Bach, but for rhythms where you don't have P waves, like sinus node Mobitz 1 exit block. It's that shortening of the cycle before the pause that's very important. And the reason that it shortens is that the greatest prolongation occurs, you know, there's progressive prolongation, but the greatest increment of that occurs in the first beat. Mobitz type 2, intermittent or repetitive failure of conduction without prior progressive lengthening of the PR interval. 2 to 1 has its own category because you don't know where the site of block is. Mobitz type 1 classically is a conduction disturbance of the proximal conducting system, or AV node, whereas Mobitz 2 is classically a distal, His or beyond conduction abnormality. Mobitz 1, you should know, though, can occur in other parts of the conducting system as well, but typically we distinguish those two, and 2 to 1 AV block can occur with either. High degree of advanced AV block means that there are sequentially non-conducted P waves, but some P waves do conduct to the ventricle. And complete heart block, not only do we have failure of all P waves to conduct to the ventricles, but we have to have absence of interference from a competing rhythm, such as what I showed you in that junctional tachycardia. So here's a straightforward Winkie-Bach. Here's point number 3 that I want you to remember. Anytime you have an irregular rhythm, we said to look in the T wave to be sure there's not an ectopic beat, but even before that, always start with the P to P interval. And if you start with the P to P interval, you'll see this is perfectly regular. And so this group beating that you see here, which could be due to several things. Group beating can be due to blocked APCs, to sinus node exit block, to a variety of things. But you see that the P to P is perfectly regular, and therefore the PR is gradually prolonging, and so this is obviously a straightforward Winkie-Bach, Mobitz type 1 block. Here's a Mobitz type 2 block, where there is sudden cessation of conduction without progressive prolongation. There is prolongation here, but it's constant. Marked first degree AV block in the setting of right bundle branch block and left axis, left anterior fascicular block, and then all of a sudden this P wave does not conduct. And then it's restored and there's an APC here. So sudden cessation, Mobitz 2 usually, if it occurs in the setting of other conduction abnormality because it's a distal block, and it would be uncommon, wouldn't it, to suddenly block in all 3 fascicles at once. So you usually already have a right bundle, a left anterior fascicular block, and in that remaining fascicle, a conduction abnormality progresses, and you have a non-conducted beat. So this one I would put as a 31 Mobitz 2 AV block, 43 right bundle branch block, 45 left anterior fascicular block, number 7 sinus rhythm, and number 13 APC. If I were that's how I would put the answer sheet. If I were scoring it, though, as a test giver, I would probably give you total credit for the Mobitz 2. Here's a patient with a 2-to-1 AV block. Just look at the top part of the tracing, please. A relatively narrow QRS, a patient having an inferior ischemic event, as you can see, and 2-to-1 conduction. So you don't know whether this block is occurring at the level of the AV node or below. You know, since it's an inferior event, it most likely is at the AV node, and since it's a relatively narrow QRS, that also suggests, and what this probably represents is a variation of a Mobitz 1 or Winky-Bach, and if you monitor long enough, you can see that in fact that is the case, because it now goes from a 2-to-1 to a 3-to-2, and this is a Winky-Bach pattern. Here's a 2-to-1 in the setting of a wide QRS, right bundle branch block, left anterior fascicular block. We'd be a little more worried here, wouldn't we, that this in fact represented a higher risk or distal block, but we could not say for sure, and it could be either one at the AV node or below, but we certainly would not be very comfortable with right bundle, left anterior fascicular block, and 2-to-1 AV block as we see here. So 32, 2-to-1 AV block, 43 right bundle branch block, 45 left anterior fascicular block, 7 sinus rhythm, and 6 left atrial abnormality. And here is just complete heart block. Not only do you have AV dissociation, none of the P waves have anything to do with the QRSs, but you also have P waves way out here in the middle of the desert that should have conducted. Certainly nothing is interfering with these, and yet they did not conduct. Complete AV block. All right, let's shift gears now and move a little bit into ischemia, injury, and infarction. Electrocardiographically, ischemia is characterized generally by ST and T wave abnormalities. Injury, we're generally talking about transmural injury or epicardial injury, by which I mean ST segment elevation. And infarction electrocardiographically generally means Q waves 25 to 30 to 40 milliseconds in duration. Acute ischemic events, ST elevation, often begins with hyperacute T waves, as shown here, evolves very quickly into the more concave classic ST segment elevation, and then evolution of the changes that you know well into Q waves, in most cases with an ST segment elevation MI, absent an intervention or other change. Here is a patient with an inferior current of injury, not great in magnitude, but clearly evident, and these associated ST segment changes here, also a PVC. These changes in the precordium here can be due to a couple things. First of all, there's a concept of what's called reciprocal changes, and it's just a simple electrical principle. If you have a current and you record it from this perspective, you may see elevation. If you record it from the opposite perspective, you may see it as depression. So one thing is that this could partly be due to this same current of injury just being reflected in the particular electrode that you see here. That's called reciprocal change. But we also know that inferior infarction classically and typically is associated with some involvement of the posterior wall as well. Commonly is associated with some involvement of the posterior wall. And so in many of these cases, if not most, this probably also represents not just inferior, but some posterior involvement of ischemia and infarction also. So this is either reciprocal or part of the inferior posterior infarction. There's no way you can absolutely tell on this electrocardiogram. My point is you do not have to invoke that you have two vessel disease and anterior ischemia occurring at the same time that you have an inferior current of injury. You couldn't exclude that, but This classically would be associated as part of the ST segment elevation MI inferiorly. We do know that when you have these kind of reciprocal or posterior changes along with an inferior current of injury, it does generally mean a larger amount of myocardium is involved. So for the test on this one, I would put number 65 STT injury, number 23 PVC, number 7 sinus rhythm, and number 64 STT ischemia if you chose. I personally would not. I would just call it the injury, which is the important part of this tracing. Here is a pattern that is one of the more common ones of patients erroneously sent home from the emergency room. I'm sure you all see that this patient, in fact, has a high lateral acute ST elevation MI. Up near the base and in the circumflex distribution, the electrocardiogram does not often show great changes of great magnitude with vessel occlusion. Whether that's the amount of myocardium involved or where it is relative to the standard electrodes, I can't tell you. But the current of injury with circumflex lesions is often not as dramatic as it is with other totally occluded vessels. But this is an important pattern to recognize. There also is a prominent R wave in V1 here, which is the Q wave equivalent posteriorly. So this would be number 55 lateral MI, acute or recent, 59 posterior MI, and number 7 sinus rhythm. For some reason, I was worried about lateral MIs when I put these together. So here's another one, which you can see here in 1 and L, and a slight little bit over here as well. Notice that upward curving. And this Q wave, even though it's not a very dramatic Q wave, relative to that QRS is an abnormal Q wave. So this is clearly a lateral myocardial infarction, acute or recent. All right, ST segment elevation doesn't always mean totally occluded vessel due to thrombus and evolving infarction. This is a patient with Prinzmetal's angina, and here is a monitor of a patient with Prinzmetal's angina. So currents of injury don't always evolve, as you know well, into completed infarctions, and this is coronary vasospasm. Here's an electrocardiogram showing an acute inferior myocardial infarction, ST elevation and Q waves. You'll notice that the ST elevation here is greater in 3 than it is in 2, and there's associated ST depression in 1 and AVL. This is highly indicative that this is, in fact, a large dominant right coronary artery causing the inferior infarction, as it does in about 80% of cases. But you knew it was the right coronary artery anyway, didn't you? And the reason you knew it was because you looked right here. And you saw there was ST elevation in lead V1, which in the setting of an inferior Q-wave infarction is strongly suggestive that there's associated RV infarction. And if there's RV infarction, the infarct vessel has to be the right coronary artery because that's where the RV blood vessel comes from. When you see this, as I say, highly suspicious, I think even diagnostic in this setting, you should do the most specific tests, though, which are the right precordial leads. And in studies, the most definite diagnostic criteria is 1 millimeter or more ST elevation in lead V4R, which you see down below. So, inferior MI, acute or recent, and sinus rhythm. Here is a age indeterminate or old inferior posterior infarction, abnormal Q waves inferiorly, and again this Q wave equivalent in V1 of a posterior infarction with slurred and more than 20 to 30 milliseconds R wave in V1 representing the Q wave. Posterior infarction, when it occurs, usually is in the setting of a inferior or a lateral myocardial infarction. There are electrocardiographic examples, though, of isolated posterior infarction. I'll show you one of those a little later on. So this would be 58 inferior MI, age indeterminate or old, number 60 posterior MI, and number 7 sinus rhythm. Okay, this is a woman with chest pain and marker evidence of myocardial infarction, and this is the deep T wave inversion pattern of ischemia or non-Q wave infarction. I show you this just to be complete, but also to be sure to remind you of the differential diagnosis of the pattern that can look very similar, and that's a CNS event, particularly a subarachnoid hemorrhage. Now, it turns out that the original description of this subarachnoid hemorrhage business on the electrocardiogram was not deep inverted T waves, they're actually upright, but tall, broad T waves that can occur because of the CNS event. So it can be either one. It can be inverted like this, or it can be upright, and it can be very difficult to tell apart aside from the clinical setting. Here, for example, a 23-year-old person having a spontaneous subarachnoid hemorrhage, and these are the ECG changes with it. Here's another pattern that I'm sure you know readily how to recognize in a patient having chest pain. You'll notice, first of all, that there is diffuse ST depression, indicating ischemia, and pretty dramatic, more than 1 to 2 millimeters. But there also is ST elevation in AVR, and the ST elevation in AVR is greater than the elevation in V1. And this is a pattern that has been demonstrated, and experience has clearly shown as correct, to be associated with multivessel advanced coronary disease or left main coronary lesion. So diffuse, marked ST depression with elevation in AVR, very high risk electrocardiogram in a patient having acute coronary syndrome. For purposes of the test, it would be 64 STT ischemia, 45 left anterior fascicular block, and number 7 sinus rhythm. Here's another reflection of ischemia. Would not be on the test, but could be, would not be on the ECG standardized test, but could be part of other questions. This is a patient, I'll let you just look at the top tracing during chest pain compared to below. You notice that there is ST depression, what we know, part and parcel of acute ischemia, whether it's on a treadmill or spontaneous. But look at this. What is this? Those are negative U waves. Negative U waves can be indicative of ischemia as well. On the treadmill, when they occur, the development of acute negative U waves is usually indicative of a left anterior descending coronary lesion. Negative U waves, persistent negative U waves, can occur with hypertension and LVH, but for them to be transient like this certainly gives rise to ischemia, and in this case as well was a left anterior descending lesion. And you can see after the pain, those negative U waves went away, so it's not LVH, it's not some persistent change. All right, some STT changes that can simulate ischemia. Well, early repolarization, you know how to tell that very readily. I've shown you examples of LVH and left bundle. We'll look at pericarditis in a moment. Hypothermia, the Osborn wave, hyperkalemia, Brugada pattern, hypercalcemia, juvenile T waves, and we've seen intracranial hemorrhage. There are a number of examples as well that can simulate infarction Q waves. I've shown you hypertrophic cardiomyopathy. I'm going to show you some neurologic disorders, amyloid and sarcoid can, chronic obstructive pulmonary disease we've seen, dextrocardia, left pneumothorax. Examples of all of these are in the books and tracings that I've given you. Acute profound ischemia can itself result in transient Q waves without substantial infarction. Usually uncommon, though, unless there is true infarction. Let's go on. Here is a classic example of pericarditis. There is diffuse ST segment elevation, concave ST segment elevation, but more characteristically, there is TA, or PR segment depression, elevated in lead AVR, representing the atrial inflammation. This ST elevation probably results from some associated inflammation just under the visceral pericardium and the epicardium, little injury that you see associated with it, and the TA depression represents the same thing in the atrial tissue, because this is the atrial ST segment. So this is pericarditis, and so on the test I would put 84 pericarditis and number 10 sinus tachycardia. Here is a shivering man. Now this would not, if this were to be on a test, it wouldn't be quite so leading a header, but he is shivering. That's the reason for this artifact here you see. You'll notice there's sinus bradycardia, but this is where the money is right here. This is a Osborne wave from hypothermia. So J-point elevation and this notch that you see here, and there can be a considerable amount of ST elevation with it after that, Osborne waves of hypothermia. The only place I see Osborne waves anymore are in some of the post-pump patients and the hypothermia protocols after cardiac arrest. So this would be sinus bradycardia and hypothermia. Brugada, I'm sure you saw yesterday, so I won't dwell on that, shown here. And WPW. The important thing here is to recognize, well, first of all, WPW, but second, that you can get this pseudo-infarction pattern. Here you see it appears to be in 1 and L and then an R, and you could say, well, gee, how do I know this isn't a posterior lateral infarction? And the point is that this is WPW. And in fact, on the test, if you were to put lateral infarction, you'd lose all the credit on this question. So short PR, slurred upstroke, prolongation, this R wave, of course, and these Q waves are actually the delta wave, the area of pre-excitation of the ventricle. And so this would be number 34, WPW, and number 7, sinus rhythm. And this is just an example of the same tracing before and after radiofrequency ablation. Let's move on to electrolytes. The hyperkalemia that you will see on the board examination, if you do see one there, I would predict, will not be as dramatic as this one. And in other material I've given you for Saturday and the board's simulation that I've prepared, you'll have a more subtle one, which I think will be more similar to what might be on a test. But this is just to make the point. Hyperkalemia characterized by tall, peaked, symmetric T waves. And this is pretty dramatically demonstrated hyperkalemia here, which I would put as 74 hyperkalemia and 66 STT electrolyte disturbance and then sinus rhythm. Here's what happens when the potassium goes up further. The QRS begins to widen, the P wave begins to widen. It's almost like you take the electrocardiogram on a string and start stretching it out. Everything gets wider. You can even lose the P waves and not even see it, even though there may or may not be conduction to the ventricle. And when the potassium rises even further, you end up with a near sine wave like this. These are all the examples I'm giving you are dialysis patients who reported to the emergency room, and all were quickly treated and effectively treated, but not recognizing that early on can have dire consequences. So that's hyperkalemia. This is one that I bet you don't recognize as often, because I don't recognize it as often as I should either, but we should look carefully for it because this is hypokalemia. And it's more common than you would think, and it's an important finding. Hypokalemia is characterized by decreased amplitude of the T wave and prominence of the U wave. You can see here the T waves are essentially gone, and what you see here and there, and most of this, those are U waves, and this is all the U wave. And so this is hypokalemia. Sinus bradycardia, prominent U wave, hypokalemia, STT electrolyte. I would also put prolonged QT on the test because you never know for sure exactly where the T ends and where the U ends. In the heart station, you would probably say prolonged QT-U interval. You don't have that option on the test. So if there's any question, you could put both, but clearly you should put prominent U wave here, and relative to the T, this is very suggestive of hypokalemia. This is a patient with hypocalcemia. you'll notice that there is prolongation of the QT interval, but it's an unusual kind of prolongation in that it's all in the ST segment. There's nothing wrong with the T wave here in terms of its duration. You do have some inverted T waves in the precordial leads, but the morphology here, the duration of the T wave is normal. It's the ST segment that's prolonged, and that's characteristic of hypocalcemia. Prolonged QT due to ST segment prolongation in the appropriate clinical setting, hypocalcemia. Here is a patient with hypercalcemia, a patient with lymphoma, and you'll notice just the opposite. There is no ST segment. You go right from the QRS into the T wave in all of the leads. In fact, this can even simulate a current of injury. So this is hypercalcemia. And here's another one, just to show you how close it can be to the QRS and how it can simulate ST segment elevation. This was just hypercalcemia. Yesterday, I'm sure you saw several examples of congenital QT prolongation. Here's just another one. And here, a pattern that happily is not present very much anymore, and that is findings of digitalis. The classic ST segments of digitalis are this sagging or hammock kind of appearance you see here in lead 2, also over here in lead V5. The manifestations that can indicate digitalis intoxication, there are several of them you should know, but the basic principle is this: that when you see abnormalities of both conduction and increased automaticity at the same time in the setting of digitalis, you should think about digitalis intoxication. So if you have non-sustained VT and you also have Mobus 1 AV block occurring in other parts of the tracing, that would be worrisome. If you had accelerated junctional rhythm, or if you had PAT but PAT with block, those things would raise the suspicion of digitalis intoxication. And one of the rhythms that can generally indicate a pretty high level of digitalis intoxication is junctional tachycardia, which is what you have here. So this would be junctional tachycardia, number 22, digitalis toxicity. If you make the diagnosis of toxicity, you don't have to make the diagnosis of effect. But my point was both of those are evident on this particular tracing. Okay, this is an electrocardiogram, obviously a tachycardia, and you'll notice that electrical alternans is present. Think this patient has an effusion? No, it turns out the differential diagnosis of electrical alternans does include supraventricular tachycardia, perhaps AV nodal reentrant tachycardia, AV more so than AV nodal tachycardia, but at any rate, SVT can be associated with electrical alternans as well. Here is the true thing for pericardial effusion and electrical alternans. Electrical alternans is much more specific if there is total alternans, that is to say not just of the QRS but of the T and P wave as well. That's less common. Here it is electrical alternans in a patient with large pericardial effusion. These are usually the ones that have the swinging heart in the pericardial fluid, large effusions, and you can generally see that as the mechanism, or at least a major contributor to the electrical alternans. So this one would be number 39, electrical alternans, number 83, pericardial effusion, number 13, APC, and number 10, sinus tachycardia. This is the most common error in obtaining electrocardiograms, and this is limb cable reversal, resulting in a pattern here with negative P wave and QRS, upright and AVR, and this is left and right arm cable reversal. The differential diagnosis is what? Dextrocardia, but in dextrocardia you would expect to see prominent R waves in the right precordial leads and going down to essentially no R wave in the lateral precordial leads, just the opposite of what you would see with normally placed heart. So this would be incorrect electrode placement. This is a patient with sinus pause, and this pause is about the same. It's about a 2-to-1 interval, and so this is likely a 2-to-1 SA node exit block. With sinus node blocks like this, since there is some little variability in the P wave itself, there often is a little bit of variability in the intervals. Makes it a little hard to precisely show that it's 2-to-1, but I think that's what it is. It is a sudden and prolonged pause, inappropriate pause, not obviously respiratory cycle or some normal vagal influence, and this is likely exit block. So in this one, I would put number 12 SA exit block, or number 11 sinus pause, sinus rhythm, first degree AV block on the conductive beats, and left atrial abnormality. This is a tracing characteristic of Brady-Tachy syndrome, where you have an SVT termination and an inordinate sinus node recovery time before you have a recovered beat. You'll notice also there is no junctional escape. So really, Brady-Tachy syndrome is sort of a diffuse conducting system abnormality. You have the atrial arrhythmias, you have the excessive sinus node recovery time, you often have an inappropriate or slow junctional escape, and there may be intraventricular conduction abnormalities as well. This is a patient with atrial tachycardia with block. I'm not sure that I need to say more than that, except that there also is a period of higher degree AV block down here where you have sequential P waves that non-conduct, 1, 2, 3, before one actually does conduct here. So atrial tachycardia, 2-to-1 block, and then higher degree block as the tracing progresses. This is an important pattern to recognize. This is a patient with multifocal atrial tachycardia, often seen in critically ill patients, patients with advanced pulmonary disease in the ICU on ventilators. And you will notice that, take any lead you want, there are several morphologies of the P wave, and there's no single one that is the dominant. So the definition typically is at least 3 different P wave morphologies and no dominant P wave morphology. This is a multifocal atrial tachycardia. There also is a PVC. What else do you see on there? Anyone see anything else? Not fair to ask you just looking up at the screen, I know, but from a rhythm standpoint, you saw the multifocal atrial tachycardia. I showed you the PVC. What's this thing here? Sorry? Ashman, absolutely. See the long pause, short, preceded by P wave, so it's not a PVC, and the right bundle, that's an Ashman beat. Good, thank you. Multifocal atrial tachycardia, number 50 aberrancy, and 23 PVC. If I were taking the test, I'd put all 3 of those. If I were scoring the test, I'd give you full credit for the multifocal atrial tachycardia. This is just a supraventricular tachycardia. You saw several of these yesterday, and so I will not spend time with that. This one I will spend time because this is an important tracing. You see these in the heart station all the time, and it's important that you consistently recognize it. I'll let you look at it for a second. It's atrial flutter, right? Pretty straightforward atrial flutter. Here, 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 and there. So this would be atrial flutter and 2-to-1 conduction. The more classic sawtooth atrial flutter shown here as well, with 2-to-1 conduction and some STT abnormalities along with it. All right, just a few words about ventricular tachycardia from an electrocardiographer's standpoint. There are 2 main ways we identify VT. One way is to look for the relationship of the atria to the ventricles. That is to say, is there AB dissociation, fusions, and captures? And since we don't often see that on the electrocardiogram because the P waves may be buried in the tachycardia or there may be other forms of interference, we can't see it, then we have to rely on a set of morphologies, appearances of the QRS complexes that just by experience and looking at a lot of electrocardiograms we know are more likely to be VT or more likely to be SVT. So here's one that goes with those initial criteria of fusions and captures. You can see a wide QRS tachycardia. You can see that there is a beat, though, that appears normal, and it's preceded by a P wave, and that's a capture. So there is AB dissociation here. The P wave is marching through, all the way through, and when it happens to hit at the right time, it is able to capture and conduct normally. And in fact, this is halfway in between this beat and this one, and so this is a fusion. So this is a capture, this is a fusion, and there is AB dissociation. Here's another fusion down over here, and you can see as well. And so this is ventricular tachycardia. Because you can't fuse two beats really from the same chamber. So fusion means one of them has to be coming from above. So if we don't see those patterns of fusions, captures, and AB dissociation, we look for the morphologic characteristics. And there are several groups that have characterized these, Hein-Wellens, the Brugadas, a variety of others, and I've given you some references in the material. Here are the ones that I find personally most helpful. If the wide QRS tachycardia has a right bundle morphology and the QRS duration is greater than 140 milliseconds, that suggests VT. Favors it. It's not absolute. Most right bundle branch block aberrancies are only 120, 130 milliseconds long. If there is a monophasic R wave or the initial part of the RSR prime and V1 is the dominant R, that's more favored, that favors a ventricular tachycardia. And if all of the precordial leads look the same all the way across, that's called precordial lead concordance, that's more suggestive of ventricular tachycardia. If there is a left bundle branch block-like morphology, if the QRS duration is greater than 160 milliseconds, if it takes a relatively long time for the impulse to get up and then down to the nadir of the S wave in V1, more than 30 milliseconds duration for the R wave and more than 60 milliseconds to get to the nadir of the S wave, or if there's a Q wave in V6 or a right axis, those are not part and parcel of a left bundle. If it were just aberrancy, those shouldn't be there. And so those are the ones that are helpful to me. So let's see some examples. Well, first of all, this is another one with fusion and capture of ventricular tachycardia. I don't know that I need to say any more about that. Here is a right bundle branch morphology, wide QRS tachycardia. The initial R is greater than the R prime, and they all look pretty similar across the precordium. So this would favor ventricular tachycardia, and in fact I've made it easy for you because you can see that there are P waves marching through independent, there's AB dissociation. So this is ventricular tachycardia and the control tracing shown below. Here is a very wide right bundle, almost monomorphic and precordial concordance. And look at that axis. When does the last time you saw a right bundle branch block that looked like that? And so this is ventricular tachycardia. Again, if you look carefully, there probably is AB dissociation here as well. And here's one of the morphologies by left bundle. You'll notice this Q sort of thing here in lead one. When's the last time you saw something like that with a regular left bundle? Look how long it takes to get up to the top of the R wave and then how long to get down to the nadir. And the QRS duration is very wide here. And so all those things favor this being ventricular tachycardia, which is what it is. This is an important pattern to recognize. Wide QRS tachycardia, left bundle morphology, with right axis. This is consistent with a right ventricular outflow tract tachycardia, which is what this one is. And this patient actually made it a little easy for us because he had PVCs that had the same morphology as the sustained VT we just saw. And then this one, you'll all recognize immediately. This is WPW with atrial fibrillation. And I just put it in there to make this point. All those morphology rules go out the window when you're dealing with WPW. This has the initial R greater than the second R. The WPW patterns can simulate many. But what you see on this tracing is a grossly irregular rhythm, at times very, very fast, approaching 300, and this is atrial fibrillation with WPW. And you even can see a hint of slurring even in these beats over here. And here is the patient's 12-lead electrocardiogram after cardioversion for that atrial fibrillation. All right, that's the last tracing I want to show you. Just a couple final points. Number one, for those of you taking the test, the intent of the board is just for it to be a fair examination of the kind of things that a competent clinical cardiologist should be able to recognize. If you don't try to overguess them, answer it as you would in the heart station, and then try to reconcile it with the answer sheet, you will do very well. They're not trying to trick you. When you're looking at rhythm, always measure the P to P first. Always look in the preceding T for buried P waves. And those are the most important things. Now, I need to re-emphasize what I've written in the book. I know nothing about the specific test you're going to be taking. I have worked with the board before in preparing other ECG examinations, so I do know how committed they are about making it a fair test of the material. I think if you do these things, approach it this way, you'll do fine, and I wish you the very best on the test for those of you taking it. Thank you very much.